Yeah, so once again, thanks a lot for joining us this morning for the UN Data Forum, an annual event organized by the UN to bring experts together to discuss developments in data and how data can help drive sustainable development. For our session, we are privileged to have experts from various countries and also certainly from different organizations to share with us their work, strategies, challenges, and the impact that they are creating. We're going to look at how we are using data to improve the financing and delivery of healthcare in low and middle income countries. And for this session, we have the following panelists. Dr. Ernest Kwaku, Chairman of National Health Insurance Authority from Ghana. Ghana is arguably considered to be one of the leading countries when it comes to social insurance because it has over 50% of the people covered. So please, it's a pleasure to have you on this panel.
Thank you, Jesse. It's a pleasure being here.
We have Dr. Jonathan Eke, General Manager for Formal Sector National Health Insurance Scheme, Nigeria, who is representing the CEO of the National Health Insurance Scheme, Nigeria, Professor Mohammed Nasir Sambo, who for unforeseen circumstances could not join us. He sends his apology, but he's ably represented by Jonathan Eke. Then we have Dr. Pavel Usu, Director of the Department of Delivery for Impact at the World Health Organization. The department of Dr. Usu is working to strengthen impact and using data, and we will hear a lot about specific strategies that they're doing to improve access to care and services. And certainly, last but not the least, we have Ms. Priya Shah, Director for Risk and Private Compliance, Privacy Compliance at CarePay, Kenya. CarePay is a social enterprise doing amazing things in digital platforms for healthcare. We have an hour and 15 minutes for this session, and I've organized it in various rounds. So what will happen is that the first session, I will be interacting with the panelists, and then I will certainly reserve some time so that the audience can also interact with the panelists. So please, for the public, you could certainly send your questions through the Q&A or the chat, and I will do my best as much as possible to ask the panelists to respond to those questions. So without much ado, let's start this session. And certainly, we all know that for 2020, COVID was the topic, and for that reason, we cannot talk about the future and data and technology without looking back and seeing the effect of COVID on our operations, on our countries, on the health systems, and the lessons that we learned from COVID, and how we could integrate those lessons in what we do going forward. So let's talk briefly about the impact of COVID, and I will ask you to keep your responses very brief, so that we will be able to address the other questions or observations. So let's start with Ernest. So if you don't mind, I will go by first name basis.
Yes, that's okay.
Yeah, so Ernest, as chair of National Health Insurance Authority, And I said one of the biggest health insurance agencies in Ghana in terms of participation, member participation. Could you share with us what the impact of COVID has been on the operations of your agency, and what are the strategies that you use to overcome those challenges?
Yes, thank you very much, Kwesi. Just to say that, you see, the ability to use technology and virtual interaction had been available, but COVID-19 gave us the impetus to overcome the inertia to start using technology for effect. Obviously, Ghana went under a partial lockdown, and that started affecting how we could interface with the public and with our providers. So we had to look at a strategy. First, after looking at the trajectory of COVID-19 infection, we realized that the community spread was being driven by offices. So we started as a strategy to try and look at how we can limit infection from us to other staff members. So we instituted a plan to try and limit the spread. So we designed a shift system, or like a compulsory leave system, where we fragmented staff into various groupings and asked some to go home and proceed on leave, while we try to maintain an essential staff strength to work. We have about 4,000 staff across the country. Once we sent staff home, we realized that some of them were so key that we still had to call them back to work. Occasionally, when we couldn't reach some of them, then we called them by phone. Then we realized that why not some stay at home, use the phone and other technological devices to interact. So that started the concept of working from home for us. And that really helped us to curb the spread of COVID-19 among our staff. And we sustained that. So that was the first strategy. Then the second thing was that, yes, having sorted ourselves out as staff, our interface with the public, the members and our providers, was still short. So then we were forced to fall on a mobile app that we had already created in 2018, which was being underutilized. So we started using it to interface with our members. We had a short code *929#, and we use that for members to renew their registration with the scheme so that they can be active, so that they can enjoy the services. Then we added on so that staff can also enroll digitally through the same application. So we bridged the gap of having to be physically present at our offices in order to enroll and re-enroll. Then having done that, the next step was the providers. How do they get facilities to be credentialized so that they can also tap into the scheme? That was also a challenge. Then we developed an online solution where now submission of credentialing was online. Then we could interface with them. The next step was that claims. How do we process claims and pay reimbursement? Then we had to fall on technology again to try and process claims. So that also helped us. And then how do we pay our providers? We're not using a lot of the technology available, point of sale and point of payment devices, and then mobile banking. So we had to do some, if you like, quality assurance and safety firewalls for our providers. Then we also started credentialing them and paying them also electronically.
Okay.
These have been some of the strategies that have helped us sustain our operations in the COVID-19 era.
Yeah, thank you very much, and it's a very insightful, comprehensive approach addressing COVID-19. Jonathan, as General Manager for NHIS Nigeria, and certainly, you know, Nigeria is the biggest economy in Africa. Could you also address what NS addressed from the perspective of NHIS, how you overcame those challenges?
Thank you very much. Thank you very much. I think before going into that, I must tell us that the structuring of the NHIS in Nigeria is a little bit quite different from the way the NHIS runs in Ghana. Actually, in Nigeria, the NHIS as a system does not purchase directly from the providers. So we use intermediaries, we call the HMOs, to do the purchasing. So that I think is important for us to understand that.
Okay.
So, yeah, during the COVID pandemic, we had our own share of the challenges, and we tried whatever we could to see that we were up and doing in providing services to the enrollees under the NHIS. First, within the NHIS system, we had the challenge that some of our facilities, accredited facilities, shut down by themselves. Some of them were converted to isolation centers. And even at that, some of our healthcare professionals were afraid to provide the services when people even could come to those hospitals to take services. All this created some of those challenges that NHS had to move into to see how we could deal with that. For the issue of some of the facilities closing and some of the facilities being used as isolation centers, we had to move to use technology to see how we could just move those lives to other nearby facilities without having to interrupt access to services by the enrollees in those facilities. So that's what we did. You see in the night, they will tell you that a facility, for one of the facilities has been converted to an isolation center. These facilities have closed shop because of whatever reason that they were given. So it was left for NHIS to make sure that there was no interruption of services for our enrollees. We will move them to the nearest facilities. We will contact using the SMS system and other ICT systems to tell our enrollees that you have been moved to the nearby facilities around so that they continue accessing service. Two, we probably realized the issue of apathy on the part, like I mentioned, apathy on the part of the professionals, especially when it came to taking care of people with what looks like flu. And all this came about because they were afraid of getting infected with the COVID-19 virus. We had to devise a means of getting to move around and provide PPEs to them across the country. What we did was to look at those healthcare facilities that have about 5,000 lives and above. From 5,000 lives and above, we made provision for providing personal protective equipment to them, and that helped to cushion some of the effects. And during that COVID, we realized that, in fact, in Nigeria, pharmaceuticals, the inflation became a big problem. What we did was, first of all, to cushion the effect on providers and cushion the effect on the HMOs as immediate step. We said the way NHIS operates that we do what we call global capitation payment to the HMOs, and monthly or 2 monthly. But what we did here was to give them a quarter payment. We made an advance payment to them for a quarter so that they will not tell you that the problem was. And that helped reduce the interface that we'll be having. During the COVID time, there was a lockdown, a total lockdown in Nigeria. So the movement, people were not moving. But the management of NHIS insisted that we should be going to work. and then the other level, lower cadres of management, were not coming to work. So that's what we did to ensure that we stayed up during the COVID, the critical period of the COVID pandemic in Nigeria. So thank you very much.
Yeah, thank you very much, Jonathan. We will certainly come back to some of these issues as we progress. And we also want to learn more about the main highlights of NHIS. And so we will come back to that, and then you have more time to add to what you said. Priya, we've seen that during COVID, healthcare technology trends accelerated. Apps everywhere, platforms popping up here and there, digital tools. And then, of course, I'm curious to know how COVID impacted upon your organization positively or negatively as a healthcare technology company.
Thank you, Kwazi. For us, we were already structured as an IT organization, a digital platform. So operationally, we just had to take our digital approach a notch higher. So we were already used to working virtually across different teams based in different countries, but moving fully virtually is what we did. And it actually brought about a lot of opportunities for us. We felt that COVID was a huge catalyst for adoption, like you've heard from the other panelists. Everybody that we've been chasing were now chasing us a little bit to say, how can we use your e-claims, or how can we change this? And even within the curfew situation, we were able to get our technology teams to help various healthcare federations to be able to set up a database to track essential workers during the curfew. So some of these very practical things that you face, we were quickly able to get our resources to set up some of these small initiatives to help even ease that kind of small challenges that we're facing. One of the things we found is that we were always structured to work digitally, but it takes both parties to be able to do that. So now we were getting a lot of healthcare providers who were actually happy to interact with us virtually, and we were able to now move away from physical onboarding to virtual onboarding. Of course, one of the things there was always personal interaction. So we were very, very quick to equip all our staff with protective gear and make sure that when the opportunity came, our staff have been vaccinated since then. So I think as a company, it was a continuous effort to see how we could take our digital approach, even a notch higher. So as I said, adoption was a huge success during COVID. We've seen more hospitals offer telemedicine services than has been in the past. A lot of home-based care, sampling being collected from people's homes, vaccinations also going to people's homes. As CarePay, because we keep the patient at the center of the platform, the patient can open treatment from wherever they are. So the need for using biometrics was kind of overtaken by these kind of technologies where you can use a one-time password, or you can use just your mobile phone to be able to open a visit virtually and fully be able to pay for that without having to visit the clinic. So there was immense opportunities, and it's been an exciting time as much as a challenging time to be able to explore and experiment on some of the things that maybe would have taken us much longer if it hadn't been for COVID.
Yeah, thank you very much. Like I also said to Jonathan, we will come back on the specific steps taken to address some of these challenges. But thanks for the concise response. Pavel, very delighted to have you here. Experience you bring from WHO, but also at the head office level, but also your engagement with countries. It's often said that COVID is jeopardizing efforts towards USC, but at the same time has also strengthened the awareness that health system strengthening is important. In your interaction with low and middle income countries, could you share with us what you consider to be some of the key lessons that have come out from this pandemic?
Thank you, Dr. Kwazi. And I would like to acknowledge the outstanding panel today and all the participants. I think that there are many lessons which we can draw from this experience. I think if to summarize, I would say two are very important, and they are also ramifications. That the response and the way the countries basically were able to adapt and manage the challenge was very much reliant upon the resilience of the health systems once, and then second was the pandemic also highlighted the importance of the social determinants of health, because we have seen that is really making a huge, having a huge difference. But when it comes back to universal health coverage, which you mentioned, I think what's important to note is that even before COVID-19, the world was off track to reach SDG target of universal health coverage for all, and also WHO target of ensuring an additional 1 billion people covered with universal health coverage by 2023. So we all knew that this is very, very ambitious, but this has presented with really a very strong high-level political international advocacy through the UN platform, through the UN General Assembly, high-level resolution of UHC, but also the very fact that the general program of work of WHO also set up this intermediate target by 2023, triggered the need to be able to measure in all countries, the really the baselines and making sure that we, through our policies, through our interactions, are really moving this number, which hopefully by 2030 we would be able to reach as much people as possible. Also, COVID showed, when it comes to resilience, that in the African region, particularly because of the resource-limited settings, that the resilience of the health system is so important. And here I'm talking not only about the elements of essential public health operations, but the entire health systems. There is no a separate health system for COVID. There is one health system in the country. And the way countries were able to quickly adapt and to quickly address those disruptions, which, it was very, very obvious that all the countries faced disruptions. Some of the countries faced on the peak of the wave quite significant disruptions for all other type of services. And WHO was able, together with the countries, to start measuring this level of disruption. There was a WHO Pulse survey on continuity of essential health services. And there is another round coming up. So that basically to understand how a health system can adapt and take better decisions in the terms of this type of shocks. So I think when it comes to digital and what the esteemed colleagues on the panel mentioned, that the digital solution, transition to digital, using more digital, problem solving through digital ways, I think it's also part of the resilient health system because it allows very quickly to find better solutions. When it comes to, I think the region in Africa, many countries also have performed relatively well, thanks in part to their more recent experience in applying basic public health tools to prevent and respond to outbreaks of infectious diseases. So that was a bit of advantage in terms of the recent institutional memory of public health measure. But at the same time, obviously, we all know that data and data infrastructure was not sufficient, especially at the very beginning, to track and to bring all the information for immediate decision making to everybody. So we also know that even mortality numbers, we are close to 5 million mortality number globally at this point in time, but we also know that this is heavily underestimated, and there are evidence of through different research and different advisory groups which are looking into that. At the same time, I think that also it's important to mention that 53 of the countries, 53%, or so more than half of the countries in the region define the essential health services to be maintained during the COVID pandemic and work to ensure this service continuity. So I think that this is also another lesson which really makes a case for using data, but also using data for immediate adaptation measure and making sure that the system, entire system, is adjusting to address a particular shock like it is during the pandemic. So I'll stop here. Thank you.
Yeah, thanks a lot, Pavel. And I couldn't agree with you more that when you said the need to build data infrastructure. I think is quite critical, and we will touch on this. But before we do that, let's take some time to also understand the work that various panelists are doing. Jonathan, General Manager, Formal Sector, NHIS Nigeria. Insurance is critical in ensuring financing of care, making it affordable. And I'm particularly interested in what NHIS is doing to ensure that millions of Nigerians who don't have access to care will get care, and what are the challenges you face in meeting that mandate? You are on mute. Yeah.
Yeah. Thank you very much, Kwasi. Yeah. Like I said, NHIS was established in 1999 with the mandate to ensure that every Nigerian who needs access has access without having to go through financial hardship. And when the scheme started operating, the first thing that we did was to think that getting the informal sector on board was the best thing to do. So from 2001 to 2004, we had a lot of community-based health insurance scheme that we set up. But along the line, we realized that this may not be the strategy to move into to cover these people, because challenges started coming. We realized first that it was difficult to sustain a large membership that are required to have adequate pools to get these people covered sustainably. And then we realized that even the ability to pay the required little contributions that we're asking them to make was even very difficult. So there was need for very huge subsidy payment. And the law that set up NHIS never made provisions for any of this. So it became a challenge. So, and that was why in 2005, what NHIS did was now to go for the low-hanging fruit. We now moved to cover the formal sector program, formal sector workers. But if you know the way the country is run, we're running a federal system with a constitutional provision that has a lot of challenges. So if you see the federal structure that we're running in Nigeria, the federal government workers are for the federal government, and the federal government is making the contributions for them. But for the subnational levels, to get them to come on board with national health insurance became an issue. So that hampered, was a challenge for us to even move further to see how we could get the informal sector covered under the NHIS. So what we did in 2014, what we called the National Health Act was passed. And that act made a provision for what I call a subsidy funding for coverage of the poor and the vulnerable within the country. Though the law says that, that it's for the primary care coverage for all Nigerians. And that is what we are now using. We call it the Basic Care Provision Fund, which came as part of the National Health Act of 2014, that we are using to cover the informal sector, especially the poor and the vulnerable. To further see that we expand coverage to the population, in 2015, we started looking for a way of getting the states, the subnational governments, to begin to set up their own health insurance systems. So that's a part of what we call the decentralization of health insurance to the states. And that we did all in a bid to see that we ramp up coverage in Nigeria. And if you know the circumstances, the economic circumstances of the country and the poverty indices in the country, you realize that it's a difficult challenge to move. But I think we are making progress, because even right now, the total population coverage, if we look at it in terms of, we have about 6.5 population coverage in the country now. And when you look about this population that we are talking, the states that are coming up are making a lot of, in fact, their own coverage is almost 1.7% of the population they're adding within a space of few years they have come. So we are making progress to see how we can get all this. And the NHIS law, which has been the major issue that's been militating against the NHIS, going that we have reviewed it. It is awaiting the presidential asset to take away the non-mandatoriness of the law. And we believe that if that law is signed with a provision that we put for an earmarked funding that we could use to move into the informal sector, especially the poor and vulnerable, I think we can move up coverage within the next few years. So that is where we are. We are making that progress. NHI started trying to cover the informal sector, but because of certain challenges, we could. But we are making a lot of efforts to see how we can do that. So let me stop like that for now. Thank you.
Yeah. Thanks a lot for sharing the progress and obviously the challenges. And I think one of the things that you emphasize clearly is the need for earmarked funding to really pay for those who cannot pay. So with that, I will make the link to Ghana, where I will ask Ernest to share with us some of the highlights of the NHIS. Yeah, they have NHIS and NHIA. So NHIS, I'm talking about the scheme now, and some of the main highlights of the scheme.
Okay, thank you, Kwesi. The NHIS is a scheme that actually, if you like, provides financial access for the poor population. The NHI is the authority that oversees the running of the scheme. Yes, we set out with a structure to start from a pilot that was done by private institutions and a faith-based institution. And we realized that we could have a national program for citizens. So we started with district mutual schemes that were operating at district levels. Then the inefficiencies showed up, so we had to coalesce all of them into a national mutual scheme. And under that arrangement, we brought on board facilities and providers from the public sector. All facilities, health facilities that work under the public sector were brought on board. Then we also considered purely private facilities and providers that were also brought on board. We're looking to make sure that everybody can be covered. So the more we broaden our base for bringing on facilities and providers, the more we bridge the geographical access barrier for members and subscribers to tap into the scheme. Then the third category that we brought on board to improve geographical accessibility were what we call the quasi-institutions. Quasi-private, talking mainly about faith-based facilities that were run by mainly faith-based organizations, churches, and other religious beliefs. Then quasi-public, facilities that were affiliated with universities and other institutions. So this is the structure that we brought on board to make sure that we have geographical access to the scheme. Of course, we firm this up with an act to cover our operations. This first Act 652 was passed in 2003. Then, because the operations and the ramifications became more sophisticated, we had to amend the Act in 2012 to Act 852. And within the framework of the law, we have been able to get a more sustainable, if you like, funding structure for the insurance. I don't know if I can go on and talk about our specific financial funding structure. Otherwise, if there's provision for it, then I will defer it to another question.
No, I think it's good if you can say one or two things about that.
This is what we did. When we started the scheme, the fund was wholly subvented by government from the consolidated fund. We quickly realized that that was not sustainable. So our act brought into being what we call a statutory provision, so that now under the law, funds came in from a more sustainable point of view. We have something we call value added tax, VAT. And out of that is a consumptive tax. Everybody pays indirectly by consuming goods and services. So we tied our National Health Insurance Levy, NHIL, to the VAT, and that constitutes 2.5% of the levy. And that is on a more sustainable basis because it is backed by law. Then also all providers of workers who pay into both formal and informal sector, who pay into a Social Security and National Insurance Trust, the pension trust, by law, 2.5% were also creamed off to add onto the scheme. Now the NHIL, which is consumptive, gives us about 70% of our revenues on a sustainable basis. Then the SNIT, the pensions levy, also gives us about 25%. That's almost 95%. So all sustainable and predictable. So we are quite cushioned about the sustainability of the scheme. Then intention premium to join the scheme by members, what they pay as premium is only about 5%. In fact, that is negligible in terms of funding. So our mainstay funding structure stays with both the National Health Insurance Levy, 2.5% of VAT, and then SNIT pension, 2.5% of SNIT, constitute about 95%. So we learned the lessons from the sporadic government subvention and moved on to statutory funding, which are earmarked only for the National Health Insurance Fund. So
am I the only one experiencing challenges? I couldn't hear, and I don't know whether it's my end or.
Hello.
Yeah, please go ahead.
Hello, can you hear me?
Yeah, I can. We can hear you now.
Can you hear me?
Yes.
Okay, sorry. So you have to give me a little more time because
I lost. No, we heard you till. So please go ahead.
So you heard me about the funding structure, the financial structure.
Yes. I lost you for just 1 second.
So we quickly realized that from the sporadic government subvention, it was not going to be sustainable. So we moved on to the earmark funding. Then we had to look at the sustainability into the future. Yeah, so we've done some actuarial projections. Can you hear me?
Yes. Yeah.
Can you hear me? We've done some actuarial projections, and we realized that for about the next 15 years, we may even have a surplus. We looked at 3 main factors: the release of the funds from government, treasury, and control accountant general. The timely release tied with prices of medicines within 1.4% of inflation, general inflation, and then we also looked at growth of the domestic product. Even for the positive growth, it doesn't matter the amount. If we put all these things together, we may be running a surplus for about the next 15 years, for the next 35 years. So we are actually on good ground by the financial.
Can you hear?
No, I think we have some problems with the
Yeah,
internet
yeah.
connection of Dr. Ernest. So maybe.
Yeah, okay. Thanks, Sandra, because I thought I was the only one having the challenges.
No,
So
no.
we will look at how we fix the internet of Ernest. But before, yeah, so let's then go to Pavel. So we've had the conversation from Ghana and Nigeria, but usually the success stories of USC, they come from high income countries.
Sorry,
yeah, they come from high income
sorry
countries.
to be rude. Am I back online?
Yes, you are back online. So we will come back.
Sorry.
Yeah, we will come back to you in the next round. So I would like to have the perspective of Pavel on this journey towards USC, and I'm particularly interested in what the WHO is doing and what it terms triple billions. And so, what is that, and how is that helping low and middle income countries to transform the future of public health?
Thank you very much. Well, when it comes to UHC, we are continuing the discussion on universal health coverage as really a strong idea as part of the Sustainable Development Goals by 2030. It is really captured under that very important idea that UHC means that all individuals and communities receive the health services they need without financial hardship. And we have two indicators to measure and to drive those developments in SDG, like this 381 and 382. So one is the average service coverage for key interventions, what we call the tracing interventions, and 382 is around financial protection. So obviously, in order to be able to capture this progress, we need to measure. And that was the entire idea of having some intermediate targets by 2023, by 2025, and really, boost that important facility of measuring and analyzing the progress. Because measuring, analyzing progress in all the countries means that you need to have data and data infrastructure for that. But also what it means that we will have the possibility at the global level, and countries will have more possibility at local level to track that progress and to identify where the major gaps are across those indicators and component indicators when it comes to very specific services. So what WHO did together with the member states, I would say, we defined these triple billion targets, as I said, intermediate targets for SDG impact, to be attained during the General Program of Work 13 by 2023. And what it also means that WHO countries, partners will really apply much more data-driven approach in analyzing progress, but also data-driven approach in designing acceleration strategy. It's very clear that we have to accelerate. We are very much off track for UHC. And COVID made it even more severe as through some modeling. It has been really now clarified that around 85 to 120 million people are anticipated to really, the progress towards even 23 targets will be slowed down by COVID. So around 100 million people will if the same trends continue, and the impact of COVID is not going to be addressed through acceleration scenario. So within delivery for impact department, what we are doing, we use data and to support countries to identify the areas that are most behind. We are looking at the trends across the last years. We are looking at the projections based on that rate of change across indicators. And that helps us all to prioritize these indicators in our planning processes, but also designing the acceleration scenarios in a way that just really would move the situation much quicker. Obviously, we need to apply more intensive interventions in order to change the course of those indicators. So, and here I cannot just really avoid saying that we also pay a lot of attention on primary healthcare because it cuts across all 3 billion targets, and one being UHC, another being healthier population, and another being better protection from health emergencies. Because investment in public health function are essential, especially primary health care, because primary health care is the first line of defense against health emergencies and the foundation for universal health coverage. And this is very, very important in the context of COVID. We see that the resilient health systems which have really strong system components, they also can face much easier and adapt to the shocks. So I'll stop here.
Yeah, thanks a lot. Yeah, so you mentioned certain elements there, which I I think are critical. Data, again, coming up, which of course is the main theme for this session, and certainly the next round. I would also like to learn more about you, how you're using data to strengthen impact and monitoring. But before we do that, Priya, on what fascinates me is that when you look at what CarePay is doing, is paying a lot of attention to financing. And we've heard from Ghana how financing is critical to healthcare. We've heard from Jonathan talking about the need to earmark. If you look at the technology space, most of the tools that we have, they are on service delivery, yeah, which is nice. But CarePay is creating a niche for itself in making sure that its platform can also address the financing of health. Because without financing, there's not much that we can do. Could you share with us what that entails and the progress that we've made?
Yes, thanks, Kwasi. So we also looked at, where does money for healthcare come from? So one of the big spends that we have in the various countries that are represented here is out-of-pocket expenditure. So with that in mind, we facilitated a health wallet, which is the basic tool that a participant or a patient can use to put in their savings. So that additionally supplements any other funding that's there. And in many of the programs we've been involved in, we've been looking towards, rather than having multiple vertical funding streams targeting specific diseases, to see how that can be consolidated towards giving a comprehensive health coverage to an individual. And those kind of things really require technology backbone, because each investor or each donor should still be able to trace the impact of their own funding, but still be able to give the individual comprehensive healthcare. So with the health wallet in mind, you can layer multiple layers of funds in there. You can put in your vertical funds, you can have personal savings, and you can have then whatever is coming from NHIF or any national or private health insurance. So depending on what the rules are, funding can be allocated to the individual. We always try and put the patient at the center of it and say, can you imagine how this person maneuvers towards a malaria fund, a national health insurance fund, a personal fund? We need to find a way of bringing all that together so that the patient gets comprehensive care wherever they require. But in addition to that, we have also looked at how can we also unlock funding for healthcare providers, because they are hugely impacted if they are not paid on time. And in some of these countries, we know that for a service delivered, a healthcare provider probably gets paid 3 to 9 months after they've given that service. So we've also had huge successes in having providers in our panel being able to borrow money against the amount of money that's being transacted through the platform. So I think there's been different elements of looking at it. We've been able to look at how friends and family who very commonly help in healthcare delivery for their family can also contribute towards this health wallet. So I think for us, we've been able to offer the technology platform and work with partners to see how best we can structure these various funding mechanisms towards giving the participant full control, as well as to put them at the center of this. Because many times we look at the healthcare delivery from different perspectives, and as a healthcare platform, we try as much as possible to ensure that it works for the participants. So the transparency that we create has been able to eliminate a lot of the waste, the efficiency that comes in. So even we think that the existing funding that's there, we could double the impact of those funds by just eliminating waste, increasing efficiency, and making sure that there's full transparency across the ecosystem. So I think these are some of the ratings is another element, right? To make the patient's voice count, there is very little information about what kind of quality of care or what kind of services our participants are getting. So with the platform, we're able to enable the participant to be able to choose, to be able to rate, to be able to critique the costs of their healthcare. And I think these are all elements in which we can make the existing funds go an extra mile.
Yeah. Well said. There's the need to bring in more money, but there's also the need to make sure that the existing money is used efficiently. Yeah. Thanks a lot. Ernest, so sorry for the disruption of internet. Facebook was even disrupted, so we are not unique in that. But I think your point was well made, and I just want to emphasize that the capacity that NHIS has, liaising with government. To the extent that now they have 70% of the cost, covered by tax. I think it's phenomenal, and I think is something that NHIA could perhaps also engage other African national insurers, to also start looking into that, because that continuity of funding is critical, for the sustainability of any scheme. So I just want to say that. A lot of questions have come in. For those who joined us maybe in the last 30 minutes or so, we're having a conversation on how we can leverage data to improve financing and delivery of care. And we are joined by Dr. Ernest Kwakun, Chairman of National Health Insurance Authority, Ghana, Dr. Jonathan Eke, General Manager for the Formal Sector National Health Insurance Scheme in Nigeria, Dr. Pavel Usu, Director of the Department for Delivery for Impact, World Health Organization, and Priya Shah, Director, Risk and Privacy Compliance at CarePay. We have a lot of questions coming in. I said that we would do them at the end, but I think it's good to, interject those questions. So, Ernest, there's a question around the fact that you talk about enrollment through a mobile platform, and someone says the poor, they do not have access. So how do you reach the poor? And then someone also wants to know more about, so maybe let's take that first. And then, but before you go into it, there's also a question for Jonathan on, someone wants to know if NHIS is also supporting sub-national governments. And I mean here, the person is talking about states to do insurance, and what kind of facility do those states enjoy from NHIS? Priya, there's a question about if you could share more insight into service utilization data that you got before and after COVID, and what that tells you about the work. And then Pavel, there's a question, I don't know whether it's for you or it's for somebody else, but you mentioned that there's one health system and not one for COVID and one for other health systems. But someone is saying that perhaps maybe setting up risk equalization fund for COVID will be a good thing. And what we've seen is that during Corona COVID period last year, most African insurers, they did not cover insurance through the insurance. They did not cover COVID through insurance, but it was covered by an independent fund, set up by the government. So, how do you respond to that? So let's start with Ernest quickly, please.
Yes. Now, what we realize is that in trying to enroll our membership, we make it mandatory that any beneficiary provides an accessible mobile number. We got this inspiration from the fact that if you take the profile of the telephony and the telcos in Ghana, their penetration is over 18 million. So we figured out that it is quite close to our penetration to, which is about 52.3% of active membership, which is around 16,108,400 members. So if you look at it, it is possible for every provider to have a viable mobile number, whether be it their personal possession or next of kin or anybody close by that they can use it. So we make it mandatory. Then the
perhaps you can also turn off your video. Maybe it will help. Yeah, I think it's better now. Please go ahead. Please go ahead. I can hear you.
Okay. So what we have done is that we make it mandatory that every registrant provides a viable phone number. And then we make our services also not only online on real help or wherever you are able to reach us, and then we are able to interface with you. That's how we solve the problem of, if you like, reaching the poor. Our scheme is designed to be pro-poor. So every strategy we formulate is meant to reach people wherever they are, however possible. So we don't have a problem with that at all. Okay. Online, offline, analog, smart, Android, we reach everybody.
Yeah. And I also think that what I can also add to that is that you are using various means to reach people. And so, some people can certainly be reached online, others through other means. But I thought it was a good observation also from the participants. Jonathan, briefly, the support for states to do insurance.
Thank you very much, Kwasi. I must say that actually it was the NHIS Act that decided to decentralize the health insurance to Nigeria, like I said earlier. And having done that, we have been giving the states support in various areas to see that they stand firm for us to move in the area of coverage of Nigeria. In fact, as we speak now, we're even in meeting with the leadership of the state health insurance agencies across the country. We were in a city called Port Harcourt. All of us are there trying to see how we can move the UHC idea forward. And we're asking them equally to tell us the areas that they want support from us so that we can move ahead and develop together. There is this, what we call our current Professor Sambo came on board, there is this initiative we call the health insurance under one roof, where we are trying to integrate everybody within a common umbrella with every player performing various roles identified. So since the commencement of the state health insurance, NHI has been giving them support in terms of legal development of their laws, in terms of development of the operational documents, even in the areas of ICT, where we have been giving them some levels of support. And that we want to continue, because that's the only way we think we can get to universal health coverage in Nigeria through the states.
Great.
Thank you very much.
Priya, briefly.
Yeah, so I think generally there was a decline in visits, obviously, for all the health facilities initially, because people were afraid to come to hospital, or there was no clarity about whether COVID would be payable in some of the insurance schemes. But we found that the private sector was very much used to billing and sending and submitting claims. All they did more was just maybe took a little bit longer. So it takes on average 30 days for claims to be submitted when they're physically done on a platform. We do it within 22 hours on average, and we gave a bit of flexibility up to 48, 72 hours. So clinics took a little bit longer. Initially, they had to reorganize themselves because now services were more virtual. So there's the whole process of identification, and basically we had to work through all those elements or processes within the clinic that need to be met before a visit can be billable. So I think there was a little bit, but because we were so closely, we work so closely with the providers, then this was something we were constantly engaging on and supporting each other through the process. I think public sector faced a bigger challenge because they're not really geared or fully geared towards working virtually or digitally, and there's a lot of manual processes. So I think there still is a lot of work to be done, and we're still supporting because we do work with the public sector. We've been able to help them with the HMIS or health management systems where required. So I think as a digital platform, we're there to support the healthcare providers and work with their processes. And it does take a bit of time to change those processes to be fully geared or more geared towards virtual interactions. But with hindsight, I think the clinics did really well in terms of still submitting their claims on time, and to be able to actually now see the full value of moving digital, and even the health aspect to having, biometric devices and having physical claim forms. So I think suddenly the whole value of supporting an efficient e-claim system and making sure that everything we do can be done virtually has become top of mind for healthcare workers. So I think we need to make this very carry forward with this and keep building on this change that has already happened, a mind shift that has already been triggered by COVID.
Thank you very much. And Pavel, briefly.
I won't be able to respond on the level of the health financing expert on the question. Mm-hmm. I think what is important from our perspective, when we do the problem-solving sessions, when we look at the trends around the data, and we trigger the discussion around which policies is better for the time being, I think we always have in mind that it has to be really measured in terms of the outcome. And I think there are a number of combinations of policies and combinations of the way services are provided. What is really important, if you are keeping the principle of universal health coverage, we need to ensure that services are provided and the financial hardship for the people is not going in the wrong direction. So I think that whatever policies we have to avoid and basically, be on the right side of the trend, that's the best. And the second is, obviously, we need really an agile way in countries to analyze the outcomes of different policies. Sometimes it's not so easy, but we should not wait too long to see that a particular new policy is doing more harm than good. And in this case, I think, again, I would say that it's so important to have leading indicators, to have data, and to be able to pick up those trends quite quickly and really reinforce those policies which are doing better and accelerate positive change, and stop policies which are, stopping the progress and they're going in the wrong direction. So I'll stop here.
Okay, thanks a lot. We are concluding. We have we have to stop within the next 10 minutes. But could you, Pavel, any thoughts that you want to share with respect to data, in addition to what you've already said?
Well, I think a few things, just to reinforce the idea that in order to accelerate positive change, we need a very agile way to manage the policies. And to do that, in addition to the best evidence, which we are bringing through our cooperation with in supporting member states, working with partners, I think we really need to converge on the type of data and the availability of data which is used for that, and use that for both for the entire cycle of the entire policy cycle, planning and then implementation, and really stimulate agile ways of implementing and managing change, looking at the data. So we just really want to reposition ourselves as WHO as part of the transformation, making sure that data is present at each step of what we do, and we take best decisions looking at the data, and also we measure the end results also looking at the data. And then this is how we think we will be able to walk the talks on our joint commitment to make measurable impact in countries.
Yeah, thank you very much. Enes, I hope you are back. Yeah, if you, yes.
I'm back. Can you hear me?
Yeah,
yes.
Yeah, we can hear you. So we are almost concluding. So within 1 to 2 minutes, if you can share with us how NHIA is leveraging data, is using data to improve its operations.
Yes, yes, quite quickly, I've already mentioned some of it, that because of COVID-19, we were pushed to use technology as an integral part of our operations. Underlying that, then we had to quickly realize that we were collecting a lot of data, both about our subscriber base and about our service operations. So why not digitize this data and then transform the data into a normal operationalization, the so-called digitalization? So first we digitized, and then we digitalized. And because of that, we are having a lot of analysis and analytics to help with our operations and make it more efficient. We've been doing great. We've been analyzing our basic data, looking at trends, and then therefore modifying our operations, correcting wrongs, and elevating efficiency. And it's been very great. We've been doing that on our own with our MIs units, but also with great partnership with our other development partners like PharmAccess. And PharmAccess is helping us a lot. At our latest retreat, PharmAccess made a presentation that drew attention to, if you like, possible misprescription of antibiotics. And that data analytics has given us the focus to be able to sharpen our clinical audit. At first, we were doing firefighting, but we're pointing to where we could have possible, if you like, misapplications. We have zeroed in down our clinical audits. It's a lot more cost-effective and efficient in getting to it. And
Yes.
PharmAccess is also helping us tend for, if you like, credentialing the tools, making it more effective.
Yeah, thank you very much. I think we get into the end. Jonathan, briefly, how is NHIS organizing data for the benefit of improving its activities?
Hello.
Thank you very much. NHIS, like at inception, NHI was given as a mandate to build a national health data bank. But over the years, because of some of the challenges that the scheme has been facing, we've not been able to. In fact, we are working almost manually. But I know since 2019, sorry, we have started building what we call the eNHIS. And with that, all our business processes, the enrollment data, even the encounter data, accreditation, all those we are working, and within the next few weeks, we will have a robust ICT system that will be able to generate all these our data electronically. So that is where NHI is now. And in terms of enrollment, we started carrying out all enrollment data. We are generating that electronically with ICT. And the next areas we are going is to be doing so that people can sit in their respective homes using technology to even engage with the system without having to go anywhere. That's the next step we are working on.
Yeah, thank you.
Thank you very much. Yes.
Thank you. Priya, there are two short questions here, and for the sake of time, you can choose any of them. So the one is about how can patients be supported? How can patients or low-income countries be supported? Patients in low-income countries be supported to use their own data to improve their care, their own care. And the other is, how do you strike a balance between privacy and using data to improve care? So whichever you choose, 2 minutes, please.
Yeah, so I try and see if I can combine. I mean, patients, I think for a long time have been not at the center of their care. So digitization and mobile phones brings them to the center of their care. It makes it easier for us to get them aware of what's going on, to get consent. Of course, that's a process, right? It's going to take a little bit of time before people understand what does it mean for me to share my data and what are the implications. But I think mainly, we've been able to help patients or clients save money, pay in bits. So, traditional insurance was an annual payment. You can now pay on a daily basis using your mobile phone. All those things open up those opportunities. But I think the biggest impact we're trying to create is also to create trust and transparency. And we think that trust and transparency will go a long way in terms of opening up the spectrum for patients to see that, yes, this healthcare insurance that I get, this is the value I get from it. This is what it costs me. This is the quality of care that I get at these facilities. This is the amount of saving, or this is how much I've used. So I think the patient needs to be very much aware. And if you think about traditional systems all over the world, the patient consumes care and someone else pays for it. And they don't really get to evaluate for what was paid, what value did they get out of that service. So I think digitization opens all those opportunities for patients to be more involved, for there to be full transparency across the system. And as I said, for the funds that are already there to be channeled in an aggregated format efficiently towards giving the care that that particular patient requires. So I think I'll stop there. Thank you very much for that session, and it was great participating.
Yeah, thank you very much to all of you. Would anyone like to add to what Priya said in terms of, supporting patients to use their own data to improve their own care, or how you're dealing with privacy issues with respect to optimizing the data, but also ensuring the privacy of patients for whom this data come from? Enes, are you on mute?
No, yes, I'm on mute.
Yeah.
Would I, because of time, let me use my opportunity to talk about something else, if that's okay.
Yeah, please.
Hello?
Yeah, please go ahead.
Okay, just a couple of quick points, and then I'll give some advice as well. First, our mobile application, USSD, is at no upfront cost to the subscriber. We, as an authority, we use our administrative overheads to cover that. So it's at no cost. It's toll free to the subscriber. And yes, our insurance started as covering basic costs of consultation, diagnostics, and then, if you like, pharmaceutics. But we've grown, and then we are doing sophisticated things, including surgeries and so. But of course, we haven't covered every benefit yet. This November, we are bringing 2 more benefits, including health, childhood cancers. About 80% of them are going to be covered. Then family planning and reproductive health is also going to be covered. So we are improving with, and we've become very sophisticated now. But yes, our coverage covers both formal and informal, as I reiterated. We are doing about 52.3% active penetration. That translates to about 16,108,400, active membership now. And it's both formal and informal. And the way forward for us, we want to deepen digitization and digitalization and using data to inform our decision. But I would like to encourage all other schemes. Also, digitization or data-driven operation is a way forward. We in Ghana are going forward to try and zoom in on what we call preventive insurance, because we realize from PharmAccess analytics that non-communicable diseases like diabetes and hypertension are claiming a lot of our burden of claims. So the future is to use our wellness centers set up by Ghana Health Service to put in primary preventive interventions. So the way we are going is to go towards preventive health insurance. For instance, trying to prevent cervical cancer from the primary level. That's the way we are going, and I encourage other schemes also to look at the future of preventive insurance.
Yeah, thank you very much. Certainly, it helps patients to improve health outcomes, and also as an insurer, if prevention is at the core, certainly it also leads to cost effectiveness. Any final words from Pavel, Jonathan? And we have 1 minute. Other than that, please go ahead, Jonathan.
Okay, thank you very much. Using data to support the patients' our release activity, we have tried to use, like NS said, the mobile technology USSD to get people to come in, enroll, you pay, and but we had a little challenge then, which I know that Kwasi, you know about that. But currently, some of our subnational health insurance agencies are beginning to take up that. And even within the NHIS, we're equally working again to see how we can get it back working so that we can reduce the cost of release coming to our offices and the rest of them and getting into, as we work to deepen in coverage, at least population coverage first before we talk about deepening in the benefit coverage for the people. So let me leave it at that now because of time constraints.
Yeah, thank you very much. Pavel, please.
Maybe just to summarize, what we think is extremely important is to ensure that global data governance mechanism is in place to ensure that data being a global health goods is used effectively, ethically, shared, and it's really equitable. And I think that also really trickles down to all levels where we can really ensure that data governance is really strong, transparent, clear for everyone, and delivers the best from what we can leverage from the power of the data. And I just wanted to mention that WHO hosted a health data governance summit, and you may find on the website the declaration of it. I think it's really promoting this idea of making a global consensus on health data governance, and the fact that the health data is a global good which has to be fully used to the benefits and to improve health outcomes.
Yeah, thank you very much. Any final comments? Other than that, I would like to thank you all. We've had Dr. Ernest Kwaku, Chairman, National Health Insurance Authority, Ghana, Dr. Jonathan Eke, General Manager at National Health Insurance Scheme, Nigeria, Dr. Pavel Yusu, Director of the Department of Delivery for Impact, World Health Organization, and Priya Shah, Director, Risks and Privacy Compliance at KEPE. Thanks a lot for your observations and insights, and thanks also to the audience for, for participating and also asking questions. Until then, it's PharmAccess and the UN thanking you all for participating. Thank you very much.
Thank you.
Thank you.